in most markets, the quality of a product is really set by demand. So for example, regulators don't go out there and worry about the quality of high-end Starbucks coffee. What happens is essentially companies come in, they compete, they try to sell a product that's desirable to consumers at the right level of quality. No one wants to buy a $10 cup of coffee, where every bean has been ground by hand. But we get the right dynamics in those markets because people will go out and demonstrate what they're willing to pay for by actually buying the product. That really doesn't happen in healthcare, of course, in part because patients can't observe easily the quality of care. So even if you go in for surgery, for example, you have a good outcome, you don't really know if it was a very high quality intervention or whether you were going to have a good outcome regardless of what the surgeon did or didn't do. And so then we have to rely on non-market mechanisms to get to the right level of quality because we think the market itself won't ensure that. So I've already mentioned physician agency, and professionalism is really what underlies this notion that physicians will serve as agents for their patients, regardless of their economic interests, that they have a duty to deliver high quality care to their patients. There are also regulatory initiatives that can help improve the quality of care. Outside of that, though, however, the way we pay for healthcare, and in particular the way insurers pay for healthcare, will also affect quality, and not only of an individual service, but also it will affect the way providers work together to deliver high quality care on the whole. And so I'm going to talk about primarily today targeted incentives for quality. That is payments that go for performance measures related to the quality of care. But it's also true that if you pay more for health care, you should get higher quality to the extent that there's any chance that patients or insurers can observe good care. That will mean providers want to preserve their market share. So pay for performance is the notion of channeling some portion of payments along the lines of a set of measures that somehow reflect that the provider is delivering services in a way that are going to give us the best outcomes. Pay for performance in healthcare is not entirely new, but it was really accelerated by a 2001 Institute of Medicine report that looked at the quality of healthcare in the US and found it lacking. And one of the conclusions this report came to was a reason for poor quality is that payment simply was rewarding volume in most cases, and in other cases was simply paying for access to a set of services globally through capitated payments. But there was no recognition of high quality, low quality. The payment system was essentially indifferent to quality. Pay for performance has really taken off since then, and it's really taken off in a particular way in terms of focusing on a set of performance measures. So thinking about performance measurement, I would first start with the notion that what we really want to pay for as consumers or policymakers is a good outcome and a good patient experience. So that's at the right side of my chart. And when you get to those outcomes, however, it must be that there's some set of processes that go on, that the provider delivers care in ways, for example, that make sure that patients take the right drugs, that they get evidence-based screening, that they get coordinated care. That set of processes may be better observed than some outcomes because they're very immediate, whereas some outcomes like death can be very long-term. And so these process measures that are in the middle of the chart here tend to be the focus for performance measurement. And we have some idea about which processes matter for good outcomes from randomized controlled trials or the best professional standards, consensus standards. There are also structure measures that have to do with the setting for healthcare delivery. So for example, the nurse-to-bed ratio in a hospital can be an important quality measure because we know it improves patient safety. So we could pay for performance on structure, on process, on outcome, and then all the way back to the beginning of my chart, of course, the front door, access to care, is going to be an important determinant of outcomes. So we could also, for example, pay providers to make sure that they have longer hours so that patients can seek care in an urgent care setting rather than going to an emergency department. That itself would be a structural measure, but if we captured the extent to which patients use primary care versus emergency department care, that could be an access measure. So paying for structure and process, as I mentioned before, has some appeal because these measures, they can be captured easily, and they're associated with the provider. They don't happen downstream like mortality and morbidity, the key outcomes we might consider important. So process and structure measures have that appeal. They're quite objective typically. We can say whether the test was done or wasn't done, whether there are 10 nurses or 5. But the problem is that they don't perfectly predict outcomes. So if we care most about outcomes, we have to think about the fact that there could be some distortion. We get a lot of nurses, but they sit around and play poker. Not saying that nurses play poker. Process measures likewise can have some distortions because, for example, many of them have to do with what services patients get, and physicians and hospitals are not the sole determinants of what services patients get. Patient behavior comes into play as well. So if the measure is about good medication treatment for asthma, if the patient doesn't fill their prescription, the provider may have done the right thing, the patient has not accepted that recommendation, and so it may be inappropriate to reward physicians for those kinds of measures. So each performance measure has a trade-off in terms of the costs and benefits of using it for an incentive. And finally, I mentioned that paying for outcomes, one challenge there is that, for example, a good outcome from primary care may be that I live to be 90. It'd be very hard to reward my current primary care physician for that. That would be a long time downstream. Those outcomes also are affected by so many factors, including patient behavior, but other things that we currently don't understand that we call random factors. They may not be random, but they're not measured, they're not well understood. And so if we reward providers for good outcomes that are mostly the product of luck, then we will neither get differences in behavior, nor will we get a very fair payment system. We always have to worry about the notion that providers who, for example, are rewarded for good outcomes, health outcomes, for blood pressure, for example, are going to avoid patients who come from socioeconomic groups or other populations that have inherently worse health outcomes. And so there are some middle ground measures here. We may, for example, look at intermediate health outcomes that let us know that the providers are having some effect on patient care. For example, we can see better blood pressure control. They're not as far downstream as heart attacks and strokes that have many other factors to determine them, but they may give us a good sense that the patient is getting better. So finally, just want to mention that there are, in addition to measurement, there are a number of other design challenges for pay for performance. We need to think about adjustment for patient factors, as I mentioned before, both because of risk, but also because of the concern that physicians and other providers may avoid certain patients. In addition to risk adjustment, there are many other design features that we might build into pay for performance. We could, for example, emphasize bonuses versus penalties. Penalties may have stronger effects, but may be very controversial among providers. And of course, the size of the bonus or penalty itself will have some relationship to the impact of a pay for performance program, as well as any potential unintended adverse consequences that we may see. And as payers design these formulas, they're always conscious of the fact that some of what is measurable in healthcare is not always the most important outcome or process in healthcare, that there's much that's unmeasured, and if we reward too heavily those things that we can measure, we'll get so-called teaching to the test. That is, providers aren't going to do all the things we want them to do that we simply can't observe very well. So provider payment systems are really critical for determining quality in the healthcare system. Not the only factor, but very important. And one way we can improve the extent to which our payment systems create the right incentives for healthcare quality is to pay for targeted measures of quality, structure, process, and outcome. Doing so is always imperfect. There'll be trade-offs in terms of the design and a number of concerns that lead us to the need to balance incentives.